When I look back and I remember fond memories of sweet days of old, fond memories they when I look back and I remember fond memories of sweet days of old.
The Alpha train is a slowly coming. I gotta keep on pushing. The Alpha.
Good evening, everyone, and welcome to tonight's event. My name is Ian Malago, and I'm the current chapter president of the Alpha Gamma chapter. We hope that you and your families continue to remain safe in this pandemic, and we're glad that we can still find connections through technology to further our mission to aid the community. The Alpha Gamma chapter of Alpha Phi Alpha Fraternity Incorporated was born in Providence, and we're excited to share our Charter Day, February 2nd, 1921, with you all. While our charter is specific to Providence, Rhode Island, the Alpha Gamma chapter consists of college brothers and alumni of Brown, Johnson and Wales, UMass Dartmouth, University of Rhode Island School of Design, Rhode Island College, and the various other institutions across the state of Rhode Island. The 11 charter members of the chapter approved by General S.S. Booker, Brother Joseph Chester Allen, Brother Clarence Aaron Burrell, Brother Joseph Frederick Starr Carter, M.D., Brother Chester Wellington Chin, M.D., Brother Clinton Leroy Henry, Brother Russell Adrian Lane, Brother Samuel Byron Milton, M.D., Brother Howard Hughes Murphy, Brother Louis Lorenzo Redding, Brother Heber Edward Wharton III, M.D., and Brother J. Mail Williams. These men embarked on a campaign of service, recognition, and impact in the Providence community. It is with this legacy that we celebrate 100 years later with more than 200 brothers duly initiated into the fraternity and a commitment to be of service to our community. It is now a great pleasure that I introduce Brother Jamie Ferguson, the Centennial Benefit Coordinator, Brown University alum, and a spring 2004 initiate of the Alpha Gamma chapter. Welcome, Brother Ferguson.
Thank you for that introduction, Brother President. Greetings, everyone. We are once again inspired by our start here in Providence, Rhode Island, and the impact that our chapter has been fortunate enough to make on this community and across the country. On behalf of the Centennial Committee, we are excited to welcome you to our sixth of 7 Alpha Conversations through you and the Providence community and beyond. On the first Tuesday of every month, starting at 7 p.m., we will have an inspirational conversation across many areas of interest, including sports, entertainment, education, and tonight, health. These events are free and open to the community, and we encourage our viewers to participate, spread the word as we get closer and closer to celebrating our centennial conversation the weekend of September 22nd, 2022 in Providence, Rhode Island. For those of you who are logging in via YouTube and Facebook, thank you for joining. Subscribe, like, ask questions, and we really appreciate your continued support. I also want to thank you for your participation in our kickoff on February 2nd event in raising funds for the Joseph G. LeCount Scholarship Foundation. We have to date raised thousands of dollars thus far and hope that you consider giving, as the Providence Alphas will use this fund to provide scholarships to deserving high school students from the Providence community. I have the esteemed honor of introducing our host for tonight, who will be Brother Dr. Ronald Anglade, a spring 1989 initiate of the Alpha Gamma chapter. After earning his undergraduate degree from Brown University in 1992, Dr. Anglade returned to New York and received his medical degree from the State University of New York Health Science Center at Brooklyn Downstate Medical Center. He completed a residency in surgery and urology at Boston University School of Medicine, and his research interests include genetic causes of male infertility and penile implants, a treatment option for erectile dysfunction. He is currently on staff at Emory Eastside Medical Center, Gwinnett Medical Center, Northside Hospital, Crawford Long Hospital, as well as DeKalb Medical Center. Dr. Anglade is a member of the American Urological Association, the Society for the Study of Male Reproduction, the American Society for Reproductive Medicine, and the Society of Male Reproduction in Urology. Without further ado, Brother Anglade.
Brother Ferguson. Thank you so
Dr.
much
Ferguson,
for that.
yes, no,
Yeah,
that's
exactly.
totally fine. I appreciate that, brother. You can call me
Man,
Jamie, though. It's totally
yeah,
fine.
Jamie, I appreciate that wonderful introduction. I enjoy the opportunity to sit here this evening and have a conversation about men's health with our esteemed brother, Dr. Griffin Rodgers, and hopefully I can do us justice by keeping this conversation going. So this evening, I'm trying to look professional, put on the white coat for all you brothers so we can get this conversation going and have a engaging conversation about health in the African-American community. But with that being said, let me introduce the esteemed brother, Dr. Griffin Rodgers. He was named the director of the National Institute of Diabetes and Digestive and Kidney Diseases, the NIDDK, one of the National Institutes of Health, one of their divisions. There are only 27 of these that exist, and this brother was named the head of one of them, which is an amazing accomplishment. And this was done in April of 2007. He has served as the NIDDK's acting director since March of 2006 and has been the Institute's deputy director since January 2001. And again, as the director of the NIDDK, Dr. Rodgers provides scientific leadership and manages a staff of over 700 employees with a budget over $2.5 million. Dr. Rodgers received his undergraduate, graduate, and medical degrees from Brown University in Providence, Rhode Island, obviously. And I must be corrected. Did I say 2.5 million? I'm not giving the esteemed brother enough credit. 2.5 billion with a B. Now, with that being said, at his time at Brown, Dr. Rodgers pledged the reactivation chapter, 7 Sources of Sin, back in 1974. So he's a little older than myself. All right. With all that, he performed his chief residency in internal medicine at the Barnes Hospital, which is in St. Louis, and at Washington University, which also is in St. Louis. His fellowship training in hematology was a joint program of the NIH and George Washington University in D.C. In addition to his medical and research training, he earned an MBA with a focus on business of medicine and science from the Johns Hopkins University. And this was in 2005, and a master's in legal studies in 2017. As a research investigator, Dr. Rodgers is widely recognized, for his contributions to the development of the first effective and FDA-approved therapy for sickle cell anemia, which is obviously very important for our community. In addition, he and his collaborators have reported on modified blood stem cell transplant regimen that is highly effective in reversing sickle cell disease in adults and is associated with relatively low toxicity. He has been honored for his research with numerous awards, and Dr. Rodgers is a member of the American Society of Hematology, the American Society of Clinical Investigation, the American Society of American Physicians, the Association of American Physicians, and again, his accolades go on and on. So with that being said, I'd like to bring Dr. Rodgers to the screen so he can share in this conversation. And we had this conversation the other day. There are brothers who have gone through the chapter who've gone on to become physicians, and unless somebody can correct me, me being spring of '92, I was hard pressed to figure out who else is a physician after I had graduated. So if anybody can chime in, that would be great. But with that being said, I'd like to ask Dr. Rodgers how he decided to go on into medicine and fulfill his desire to become a physician.
Yeah. Well, we all had our paths that we took. First of all, thanks for a very kind and generous introduction, Brother Ron. We all had our paths that sort of led us to what we're doing. In my particular case, of course, I was interested in medicine at a fairly early age because science and math, came natural to me. My mother was a public health nurse in New Orleans, and she occasionally brought me around to visit individuals there on the weekends to give them vaccinations and other things because they couldn't make it to the clinics during the day. And I didn't know what the term was back then, but I was struck with the chronicity of diseases within our population. I saw people with amputations because of diabetes. I heard about people who required dialysis. And I mean, I was seeing firsthand the effects of poverty and health disparities. But what really got me motivated in a research career, as opposed to just a career as a practicing physician, was an occasion in high school where I had 3 friends who actually had sickle cell anemia. One died when I was still in high school, and the other 2 died shortly after I matriculated at Brown. And back then, there was very little that you could do. And I thought that this was something that I could sort of apply myself towards. And, to make a long story short, as you mentioned in the introduction, I was privileged to be a part of a team that developed the first FDA-approved therapy for sickle cell disease called hydroxyurea. And subsequently, we've worked on transplants and more recently on gene therapeutic approaches. So work has been covered actually on Discovery Channel and 60 Minutes recently, actually. So that's what got me interested in science and medicine.
Well, Dr. Griff, let me ask you this: for brothers who may not have a full understanding of it, is what you do. How much of your practice is clinical, day-to-day sort of dealing with patients, and how much of it is spent in the research lab?
I would say,
and how common is that for both sides?
It's a little bit uncommon. What I would say was I've been at the NIH now for about 38 years. And when I first came, I was almost exclusively working 70% in clinic and 30% of the time in a research laboratory. Over time, that has evolved a bit. I still see occasional patients, but I would say 75% of my time is spent in administration, managing this budget and the personnel. 20% really is working in a lab that I still maintain at the NIH, and that's really very little time. And and I still see occasional patients. There are patients that I've seen, almost on a continuous basis for the last 35 years, not only in the States, but many of them come from various parts of the world for a yearly visit. But that number of them are vanishingly small now, I would say.
Now, Brother Griff, our topic this evening is to address some healthcare issues in the African American community. And obviously, it's a very broad topic. But what I want to do is hope at least come up with a couple of topics that I think can relate to most of our audience. So when we think about some of the major issues that affect us as a people, think about diabetes, hypertension, issues of that sort. So I'm going to ask you to speak to those two initially, and what your take is on how that affects us generally as a
Sure, no,
population.
absolutely. In fact, what I would say was that specifically of the clinical mission of our institute, I would say are sort of three things that not only are very common and chronic and costly and consequential, but they're within our mission areas. And just adding to that, diabetes, of course, that's within our name, but obesity, which is also very common in our community, unfortunately. And the obesity epidemic in this country is actually what's driving the diabetes epidemic, specifically the type 2 diabetes epidemic. You mentioned hypertension. That sort of goes along with obesity and diabetes, but they are all conspiring in a way to drive sort of a third epidemic, and that is in chronic kidney disease, ultimately in a certain population leading to end-stage kidney disease and dialysis of a requirement, either that or a transplant for to sustain life. So those are three major areas, 4 areas that our institute has been focusing on. And what I would say is that the work in NIDDK, we'll call it in short, from now, really focuses on both conducting and supporting research to look for new diagnostics, new therapies, and eventually cures for all of these conditions.
Now, a lot of patients that I see, and particularly people of color, will say, well, my diabetes, my hypertension, those are all genetic. Those are family traits. There's nothing I can do about it because my mama was a diabetic. My daddy was a diabetic. What do you say to those patients?
Well, it's interesting, but there are certain things that are genetic, and there's no question about it. But there are risk factors in addition to the genetic risk factors, many of them, sort of being lifestyle choices. Now, of course, our genes is not something that you can modify, but some of the lifestyle choices we can. And so, we really should talk about the lifestyle modifications that would be effective not only for obesity and diabetes, but for preventing chronic kidney disease and others. It is said that genetics are important, don't get me wrong, but some have said that our genetics, sort of, to use an analogy, loads the gun, but it's really our environment that pulls the trigger. And there are certain aspects of the environment that we can change. How much we exercise, how we try to keep a healthy weight, for example, how much we spend in doing activities that'll kind of lessen our stress, for example, how physically active we are, what kinds of foods we choose to eat, for example. Those are things that are certainly modifiable and would have an effect not only on those conditions, but even conditions obviously within your bailiwick in the area of certainly benign urologic diseases, but even prostate cancer, for example, which I hope we have time for you to say a few words about as well.
Yeah, I mean, as we get towards towards our conversation, I definitely want to touch on some of the urological implications that African American men or the African American community faces as a whole.
Mm-hmm.
I'm going to pivot back to sort of your areas of research because you are the expert, and we want your knowledge about sickle cell. Okay,
Mm-hmm.
and I don't think I asked you about this previously, but while I have you here, Where do you think that is going as far as treatments, as far as the genetic basis of it, our understanding of the disease, and are we close to a cure for it, even from a genetic standpoint?
Yeah, well, that's a very good question. Sickle cell disease, as it turns out, was the very first genetic disease recognized. It was actually recognized in a classic paper published by Linus Pauling, that a lot of people know him for, his work in vitamin C, but he developed this technology to separate proteins by their electrical charge on a device called an electrophoresis device. And he was able to actually show that people with sickle cell disease had hemoglobin that so-called migrated on this gel at a different rate than people who had normal blood, or people who had the trait actually had two varieties of this hemoglobin. And just based upon that observation, he inferred that protein was related to differences in their genes, and that later sort of set the stage for understanding what that genetic defect is. Turns out that, in our whole human genome of 3 billion base pairs, there's only one base pair different in a person with sickle cell, the sickle cell trait, and there are two base pairs because they inherited homozygously with sickle cell disease. So 2 billion base pairs, two genetic defects, single base pair defects, and a whole genome of 3 billion base pairs. That's sort of the equivalent of 1 second in 100 years. So imagine the consequences that has happened as a result of that just one defect. And that, what I can say is that, since it's a disease of the bone marrow, an obvious cure for it is to take the bone marrow of, say, a sibling that doesn't have sickle cell disease and transplant that in to the recipient with sickle cell disease, and the person would be cured. In fact, that's some of our recent work, but it turns out that only about 25% of patients have a sibling that is a close genetic match. And even of those that are close genetic match, some of them may have medical circumstances that really doesn't make them eligible to be bone marrow donors. But nonetheless, if you're lucky and you have a match, you can potentially be cured. Where we're moving with the science, though, and this relates to other diseases as well, since we know what that genetic defect is, technology exists now where one can actually go into the cells that are producing the hemoglobin, namely the bone marrow stem cells, and correct that single gene defect. This is something that my lab is working on at the moment, and then ultimately give that bone marrow back to the individual. And we assumed that this technology would be available about 15 years ago. We began collecting cord blood from people in the greater Washington, DMV, Washington area, cord blood in infants who are at risk of developing sickle cell disease. So ultimately, when this technology is better defined, we will be able to actually take that cord blood to make the changes and then infuse those cords back into the individuals. That way, we don't need to look for sibling donors, and we would be freed of actually needing immunosuppressive therapy to sort of wipe out their bone marrow, because this is their marrow that we're giving back to them.
Okay, well, the reason I digress to ask you that question is just that I deal with sickle cell patients as well and their issues, so I thought it'd be great to have my expert here.
Yeah, absolutely.
So now another topic that I want to briefly ask your opinion on, because it's obviously the hottest topic out there, and it's really why we're doing this not in person on a Zoom call, is COVID. Okay, and particularly COVID-19 as it relates to the African American community and the current Delta variant. What is your take on that? And in Georgia here where I am, our kids are going back to school. There's mask mandates in one county, no mask in other counties. Our political climate here is one in which wanting to wear masks or taking the vaccine may be sort of more political than medical. So what is your take on all that?
Yeah, well, I spend actually a fair amount of time in sort of discussing this issue and trying to get the word out for the absolute need for vaccination, particularly in our community, with these diseases that you've ticked off: obesity, diabetes, chronic kidney disease, hypertension. They're all major risk factors for, for the development of COVID. Not only the development of COVID, but actually the more severe outcomes. And we have vaccines now that are highly effective. They're certainly highly effective against the original strain, and even quite effective, against these variants: alpha, beta, the gamma, now the delta variant. And so we're doing all we can, and I have a sort of a weekly PSA radio show. It airs in 38 cities, including Atlanta. For example, last month, actually, I had Tony Fauci, one of my colleagues, on as a guest, and we described over the month, the importance of vaccines, destroying some of the myths associated with vaccines, why it's important for our community to be represented, and also sort of a pitch out for clinical trials and why it's important for us as a community to be engaged in this. We talk about health disparities, but if we don't participate in the next sort of version of clinical trials, be it against infectious diseases or in other areas, this will further exacerbate the health disparities, because we won't know, if we're not represented, we won't know, whether the therapy is in fact effective for us. I can tell you that, spent a fair amount of time in actually speaking with some of the companies, Pfizer, Moderna, Janssen, to try to strongly encourage them to include underrepresented groups, in the early clinical trials in which this was based, so that one could extrapolate the results based upon, race and ethnicity. And we were fairly successful with that.
Now, what would you say to the people who would say, oh, well, particularly in the African American community, the vaccine wasn't, like you said, it's not been studied in us. It's not, I have distrust in the medical community, so on and so forth. Should I take this vaccine?
Yeah.
How would you help to dispel that sort of attitude?
Well, there are people that, basically, if you provide them with the information and you try to better understand what their concerns are, in many instances, you can get that across. A better, perhaps a equally effective way is to get people within their community that they look to for guidance, to serve as a surrogate. And sort of many of the people on listening to this know that certainly within the African American community, churches are places where people get a lot of their information. They figure it's credible. They're not trying to sell anything, and they're genuinely interested in their well-being and their family's well-being. So using churches, places of worship, barber shops, other places where people, tend to go and get their information that they consider to be reliable is a way that we've been able to get out the message. I would say within the last 2 weeks, largely because of this redoubled effort, as well as what people are hearing now on television about the Delta variant and this another surge occurring, that particularly in our community, we're seeing a great increase in the people who were previously vaccine hesitant, who are now actually coming out and being vaccinated, particularly in the areas in the South, Louisiana, Arkansas, Georgia, Florida, in fact. So the people who are now seems to be holding out are doing it for, as you correctly commented, for political reasons. And, I think until all of us are safe, none of us are safe. We also have to sort of focus on that population as well.
Yeah, I mean, I can't agree with you more. And the thing that I always try to take across to my patients is that even though you may hear about some occasional side effects or outcomes, in general, the vaccines are safe, and that the quicker we all can get vaccinated, the sooner we can get back to sort of a normal life.
Right.
I'm going to pivot again a little bit to some of my areas of concern, and how they relate to some of the things we've already discussed. So when you talk about diabetes, you talk about hypertension, one thing that I deal with a lot in my practice is erectile dysfunction,
Hmm.
right?
Hmm.
And sexual dysfunction. And, for the men in the audience, that may be of concern or not. And as we all get older, it may be of concern, but also for their spouses, their loved ones, that may be a concern on the female end of things. So, what I try to tell my patients is that these factors that you discussed, diabetes, hypertension, obesity, can all be risk factors to developing erectile dysfunction and sexual dysfunction. And smoking and heavy alcohol abuse and sedentary lifestyle can all be also risk for that. Um, so if I identify ED as one of these major consequences, what else other than diabetes? Are there other issues in which you try to remind folks that they need to take care of their bodies, or because this is going to happen? This is the natural progression of your disease.
No, absolutely. In fact, I didn't get a chance to sort of go into the specifics of the information, but among, for example, people with type 2 diabetes, the current number is about 30 million people in this country with diabetes, largely type 2 diabetes, but another 84 million who have pre-diabetes. And oftentimes, particularly those who have very early disease, they have no signs or symptoms, but frequently, actually, erectile dysfunction (ED) is maybe the first symptom that will make them aware of it, and it
And
oftentimes occurs, in the context of people who are a bit overweight and have early either pre-diabetes or frank diabetes, and so that's certainly a factor. You mentioned the smoking. We tell people routinely about diabetes, for example, to mind your A1Cs or ABCs, with the A being the hemoglobin. A1C is a good measure of how well your blood sugar is controlled over a period of 3 months. Your B, your blood pressure, and your C is the cholesterol. And then the S stands for stop smoking, because, obviously, even though we have to eat to live, we certainly don't need to smoke to live. And that has so many major, effects, adverse effects on the vascular system, particularly the microvasculature that exists in the eye and in the, genital urinary tracts as well. And so oftentimes you may be the first person who would pick up this early on. And it's amazing if you can get people to lose a little weight, to get their blood sugar under control, or if they have prediabetes, we can actually prevent, in many instances, that from moving forward to diabetes. You may be the first line of in terms of defense, in terms of telling people and advising them of this isn't, you're not, absolutely, it's not going to happen. There are things that you can do to prevent it. So let me tell you about what you need to do.
yeah, you're 100% right, because usually a guy will come in and say, "I got diabetes. My vision is affected, my kidney function is poor, but I can't get an erection." That's a problem, doc.
Right.
So
Now
let
it's
me
a
come and
problem,
see
right?
you. Yeah, exactly. So with that being said, first of all, I want to remind everybody, if you have any questions, please send them in. This conversation is fairly short, and I know there may be a lot of questions in our discussion. I'm going to take a moment, however, to speak about something that is important to men of color in particular, and that's prostate cancer, something that
Mhm.
I deal with on a daily basis. So, in general, as we talked about some of the genetic basis of disease, we can say there is a felt to be a slightly genetic risk factor associated with prostate cancer, particularly family history.
Mhm.
Another thing you mentioned is when you talked about your PSAs that you do on the radio. All I can think about is the PSA that I get
Yes, I know.
pretty routinely on most of our men. And I'll tell any brothers who are on the line that as you get into your 40s and 50s, it's important that in addition to the ABCs that Dr. Griff spoke about, you should also know your PSA.
Mhm.
So I tell everybody that you know your blood pressure, you know your weight, you know your hemoglobin A1C, but you should know what your PSA is, and that's a number that you should monitor throughout your life. So if it does change in any significant manner, that may require a visit to see me.
Mhm.
So in general, not to cite statistics, but we'll say that African American men are at higher risk of getting the disease and dying from it. I do suggest that early detection and early treatment options are the cure. I'm sorry, are the basis of doing well with the disease. So I think that as you enter your 40s, particularly if you have a family history of prostate cancer, you should make sure you're getting screened. Men of color, as you enter 45 years old, should start their screening almost regardless of their family history and risk factors. And in my opinion, and sort of the opinion that seems to be taking more of a hold, screening is not just a PSA blood test. It also requires a physical examination. And as distasteful as most men may say it may be, that requires a digital rectal exam or a finger in your bottom to check your prostate. So I'm going to put that out there. So if anybody has any questions about that, please
Some people call
put it on
call
there.
it being digitized.
Yes. So, I'll tell you, earlier in my career, I used to apologize for it and sort of make excuses. Now I just say, look, drop the pants and let's get this over with, because I don't want to do it as much as you don't want me to do it. So let's get this out of the way.
Right.
So let's see, what else are we going to discuss? So with that being said, if there was any take home message this evening as to what we as a community should look out for
Mhm.
and how we can improve our health in general. I'm going to throw that to you first as our expert, and then I'll tell you what my thoughts are.
Yeah. So, oftentimes people, will get of this opinion that, diabetes or kidney disease or some other chronic illness is something that just runs in my family. My father had it, uncle has it, mother has it. And so, it's just going to run its course. That's just how it is. But I don't think, what we've learned today is that you really shouldn't take this fatalistic, approach, that there are things that exist today that are quite effective in terms of prevention. There are things that are currently being studied that may bring us to, another level in terms of prevention or treatment or eventually cure. And again, this people will say, well, when we go to the doctor, they always tell me the same thing: you should eat better and you should exercise. But that is absolutely the case. Oftentimes, these diseases don't run by themselves. People have diabetes, they have arthritis, they have high blood pressure, and simple things like, um, keeping, sort of a healthy weight and exercising. And when I say exercise, it doesn't mean that you have to join the gym or buy a Peloton. Just walking 30 minutes a day, 5 days a week has been shown to reduce your risk for developing diabetes, kidney disease, cardiovascular disease, a whole host of cancers, as well as keeping your weight, under control. And in terms of, sensible eating plans, I don't like to use the term diet because diet sort of infers something very short term. You might know the kinds of foods that, are not sort of best for you, but certainly, portion size and when we eat is just as important. And what period of time of the day that we eat is also just as important as what we eat. So those are things I really want to sort of leave the audience with, the idea that they or their family members, when they bring up these fatalistic views, to disabuse them of that and say, listen, there are things that you can do. And, just to put in a plug, we have a host of materials, on our website, and there it is listed as we speak, written in multiple languages, to try to give people information that they can use in terms of keeping a healthy weight, preventing diabetes if it runs in the family, preventing chronic kidney disease, and it's just a plug for the website. Next to the IRS, the week before your taxes are due, or Social Security, our website is the most frequently visited website among the federal agencies, the third most frequently visited among the federal agencies. So let me turn it to you, Ron, for your advice.
Yeah, so Brother Griff, I agree with you 100%. I mean, everything you said, I echo that. I really am, and even for myself personally, I'm a firm believer in exercise and sensible eating, and limiting risk factors that we know are bad for smoking, excessive alcohol, so on and so forth. Although maybe my youngers may have been different, but currently, we know that we have to stay healthy as we get older, right?
That's right.
Yeah, so I'm going to leave just one anecdote about being healthy. So generally, I get guys who come in their 40s or 50s and say, Dr. Anglade, it looks like my genitalia is shrinking. My penis isn't as long as it used to be, right? And I say, it's not necessarily that your penis is shrunken, it's that your belly has gotten fat. So if you lose 20 pounds or 30 pounds, you'll probably get some of that link back that you want. So I always tell men, stay healthy, maintain your weight, exercise. And with that being said, I'm going to circle back to another complaint I get a lot of. And brothers, please, or anybody on this channel now, please send questions. Is low testosterone. The vast majority of men, as they get to this age, the middle ages, I have low T, I have low T, I have low T. And a lot of it is not necessarily that their testosterone is low, it's that their body composition has changed and that their lean muscle to their fat distribution has changed, composition has changed, and so the testosterone that they had before is no longer as effective as it once was. So again, and there's other issues we can get into that, but the take-home message I would say is everybody try to be as healthy as you can, try to avoid things we know that are bad for us, and maintain a healthy weight and exercise.
Mm-hmm.
So with that being said, I think we are towards the end of our time. We are going to open this conversation to questions. And I really do appreciate you, Dr. Griff. This gentleman, I will say, is modest beyond all means. This gentleman runs one of the National Institutes of Health, a budget of $2.5 billion, 700 employees, sickle cell cure or treatment. So if you have any questions, gotta send them out right now. So anyway, I'm going to start with a question from from Jeremy Duro, Esquire. Okay, and he writes that Dr. Rodgers, you mentioned the trait. Can you talk about the dangers of the trait? As a child, I remember being told the trait alone created no clinical problems. In the last several years, though, it has become clear through news reports that under some circumstances, the trait can be very dangerous and even life-threatening. Can you give us some guidance as to the trait versus the actual disease, and what are the things one should look out for?
Yeah. So that's an interesting question. Thanks for raising it, Jeremy. In terms of sickle cell trait, there are a handful of medical consequences that have been replicated and people firmly believe. For example, people that have sickle cell trait have, in certain circumstances, a greater chance of concentrating their urine, and as a direct result of that, can become dehydrated much more rapidly, particularly in hot environments. And so the message to them, just like the message to most people in hot and humid environments, is that you should remain well hydrated. Women during pregnancy who have sickle cell trait may have a higher risk of developing urinary tract infections, for example. People who get hit in the eye may develop eye problems at a greater risk. And there are other kidney-related issues that occur, much less frequently. But beyond that, there really are very little complications associated with sickle cell trait. Let me point out that we've actually heard this maybe in the news recently about people with sickle cell trait actually developing full-blown sickling, and that causing the same problems that it causes to people with sickle cell disease. That doesn't seem to be the case. Many of you may have, sort of followed the case of this expert witness came in and said what killed the brother in Minnesota was not the fact that the guy was on his neck for 9 minutes, but that he had sickle cell trait, and then he was inhaling the exhaust from his car, and he had general sickle cell crisis. That was not the case, and that was actually predicted about 30 years ago by a very prominent pathologist at the University of Chicago. He called it the medicalization of sickle cell trait because this was being used in court cases. That's just absolutely not the case. And so there's very little evidence that, except for those few conditions that I mentioned, that sickle cell trait carries a risk. It was pointed out that, for example, in professional athletes, football players, basketball players have the same frequency of individuals, African Americans with sickle cell trait, than with normal blood. One would assume that if they did have problems, they really would have been selected against and not reached that level of elite athletes. So I would just say that that's really not an issue.
Okay. Well, Griff, thank you so much for that explanation. And again, Brother Jeremy, thank you for the question. I'm going to go to a question that's posted by Sheba Hakiza, I think if I got that correct. And her question is, my father is 80, a diabetic, and has high blood pressure. He recently started dialysis. And her question is dialysis a lifetime treatment? Is there any way to reverse kidney failure and get off of dialysis? And do you recommend any supplements for the lack of appetite and weakness that a lot of times affects people on dialysis?
Yeah. Sheba, that's a great question. I wish I could tell you right now that we could reverse kidney failure. Your father is 80, has diabetes. Usually people with diabetes, since that's a risk factor for kidney disease, we strongly encourage them to be, periodically tested to see what their kidney function is, because you can change potentially the trajectory of going from early kidney disease to end-stage kidney disease requiring dialysis. There are new therapies that exist. You're hearing them on the radio or on the TV now, these drugs that are used to lower blood sugar, but at the same time, they're actually decreasing the risk of cardiovascular disease. And it turns out that they're also decreasing the risk of end-stage kidney disease. And so 20 years ago, there were other classes of drugs, so-called ACEs and ARBs, angiotensin converting enzyme inhibitors and receptor blockaders. But at this point, dialysis is the life sustaining therapy. We are actually working on what you're just saying. People who have early stage kidney disease, we're currently investigating how one can reverse that kidney disease. And people who have actually later stage, not yet end stage kidney disease, we're developing we have developed a program called Rebuilding the Kidney, and which we're looking at tissue regeneration and what are this is currently investigation, but what are the factors that one would have to add to either regenerate an existing scarred kidney and to get it to function better, or alternatively, we're funding a group of investigators who are actually taking kidneys and in a way doing 3D printing of the kidneys, putting in certain cells that have to interact with one another to actually develop a bioartificial kidney using the patient's own cells, and then ultimately replacing their kidneys with this the bioartificial kidney. It's an effort that's underway. It's going to be about a 10 or 15-year effort. It's called Rebuilding the Kidney Initiative, and that's where we're going. And that's why I say it's so important that we not only make ourselves aware of what's currently available, but also participate in these trials so that you'll be at the sort of the cutting edge of the next wave of effective therapies.
Dr. Griff, I'm going to interrupt you for a quick question. I'm going to ask you one of my own. Our time is short. What do you guys say, or what research do you have as far as kidney stones?
Mm-hmm.
Okay, because I'm a urologist, deal with kidney stones all the time, right?
Mm-hmm.
And in my line of work, I say there's a genetic base of kidney stones. Dehydration is a risk factor. Anything particular in people of color that you would speak to that I might not even know of?
Yeah. So a couple of things that are currently going on. One thing is actually reminding people that once they've had a kidney stone, they're at a greater risk of developing another kidney stone. And so in terms of therapy for the stone, developing new technologies that would allow one to ablate these stones using lasers or other thermal or wave treatments to crush the stones so that they can be passed. A second active area of investigation is to remind people that they need to remain hydrated. And so we actually have a fairly straightforward study that's currently ongoing that uses these devices to remind people through their wearable devices that every few hours you need to hydrate in a certain manner, and this allows for positive reinforcement once they do that. And the question is whether doing that sort of daily reminders versus general reminders going out on a monthly basis will change the frequency of subsequent kidney stones. Some of these kidney stones, as you know, are caused by the body's inability to metabolize oxalates, for example. And we've been working with investigators realizing the importance of the human microbiome. That is the hundreds of billions of species that exist in our gastrointestinal tract, viruses, bacteria, fungi, and others. Some of these bacteria and the composition of them have unique properties of actually providing for the body additional enzyme activity that might substitute for that which is deficient in people who have these tendencies to form stones. And so changing the microbiome, either by probiotics or prebiotics, is an area of investigative inquiry at the moment. And so that's another sort of line of investigation looking at the kidney stones. There's an area, as you probably know, in the southeast known as the Stone Belt, where there's obviously a big genetic predisposition to that.
Well, Griff, thank you so much for indulging me with that question. But I'm going to go back to our listeners, and there is an excellent question from an Ebony Pickett, and I think this is very timely. Her question is are there any contraindications for the COVID vaccine for her son who has sickle cell disease, not just trait, but the actual disease?
Yeah, I would say no, unless your son is allergic to some component of the vaccine itself. We are certainly encouraging, and he's 15, and so certainly the Pfizer vaccine at the moment is available for the therapy. Obviously, there are certain medical circumstances that I might not be familiar with about your specific son, so I would encourage you to speak with your pediatrician or your pediatric hematologist before, but overall there's no contraindication, in a general way. In fact, unfortunately, people with sickle cell disease, as are people with other chronic diseases, are at greater risk for getting infected, and also if they are infecting, developing more severe disease. So I would strongly encourage you to follow up with that.
And then a follow-up question to that from the same listener is that she has 2 children who are currently on hydroxyurea, and I imagine they're relatively young. Any studies on the lifelong impact of being on a medication like that and sort of risk benefits over time?
Yeah, actually, I'm glad you asked that, because that was actually the drug that we helped to bring to. So I have to, first of all, make sure that I let you know that I'm not getting any royalties or any benefit, because the drug was actually generic when we started using it. It was first, since I'm an adult hematologist, first approved for adults back in the 90s, and then with subsequent studies in teenagers and in adolescents and then young children and ultimately infants, the FDA in 2017 later extended its approval to include these populations. And hydroxyurea, as it turns out, is probably more effective in children than it is in adults. In adults, it's effective in about 75%. Children, that number is closer to about 90%. Not everybody responds, but if you do respond, you can enjoy less crisis, a better hemoglobin level, and therefore less transfusion. Chronic organ disease damage seems to be stabilized and in some instances reversed. But there will be occasional problems. In terms of the long-term benefit profile, unlike other forms of chemotherapy, there doesn't appear to be those types of complications associated with hydroxyurea.
Okay, so now I'm going speed round. I have one more question I want to get in. Okay,
Sure.
this is from Brother Walt Wilson. Okay,
All right, my boy.
all right, he's got
My
one
line,
for
brother.
you. He says the COVID-19 Lambda variant, Lambda variant is a variant of interest. Is there any new information on the vaccine resistant from this variant, or are we still sort of in the dark as to how the vaccine will play out in our defenses against this variant?
Yeah. So first of all, just a word about the nomenclature. You know, you may remember our previous president decided to call the first variant that we had the Wuhan virus and the Kung flu and a whole host of derogatory comments about its origin, and that's what ultimately led the World Health Organization and other groups to kind of name it, by sort of the indifferent alpha, beta, gamma, the Greek alphabet. The variant that Walt is posing, this Lambda variant, as all of the brothers know, their Greek alphabets, is now after Delta. It was previously found, if I recall correctly, actually in Colombia, South America, and it is currently at a fairly high level in certain areas in southern Florida. What we know so far is that it exists based upon the genetic sequencing of the virus. It is distinct from Delta, but we don't know yet whether it is as infective or more infective as the initial variant, the Alpha variant, or Delta. And even if it's more infectious, is it more virulent? Is it going to be associated with more complications? Since it was just sort of seen in this group, I think there will be two pieces of information that would lead one to conclude that. And that is, you'll see the numbers, which I understand in certain areas in Florida, are hovering around 3 or 4%. But in the next several weeks, if that number suddenly goes up to 10% or 15%, that would imply it's more infectious. And then if you see most of these people being hospitalized, intensive care unit, on ventilators, that would imply it's more virulent. So it'll take time to sort that kind of thing out.
Okay. One more question. Okay. And this is again, topical COVID boosters. What is your feeling about a booster shot? We had a conversation ourselves, and we were early vaccinators or vaccinatees. What are your feelings? Are we going to need a booster?
I think that eventually we may need boosters, but there's very little evidence at the moment for the people who got it, even back when it first came out in December and in January. We are now sort of 6 to 7 months out from our last vaccination, and the information that the company Pfizer is sharing is largely based upon data that has come out of Israel. In Israel, everyone in the country who did receive a vaccination received a single Pfizer vaccine, and that was done, very early in the course. And so they have information now on these individuals who participated in their trial out 9 months, a year, even longer. And it's in some of those, particularly people over 65, for example, that they're starting to see some waning in the antibodies that one can detect in their serum and the neutralization properties of those antibodies. That doesn't immediately mean that those individuals are going to get sick or have so-called breakthrough infections, it only means that they can test one assay that is, a rough surrogate for, the likelihood that they will be infected. It'll really take some time. And again, that's, information only in those who receive the Pfizer vaccine. It really says nothing about those who receive the Moderna or the J&J. My understanding, though, is that, with this technology that was used by Pfizer and Moderna, the so-called mRNA, that they can quickly develop and then scale new vaccines, either single or polyvalent, that would be directed, for example, against the Delta variant, the Lambda variant, and at the time it may even be something else, and that can then within a few months be provided to a larger proportion of the population.
Well, Brother Griff, I'm going to thank you this evening. I think we had a wonderful conversation. Again, sir, you are a scholar and a gentleman, and I appreciate your time this evening. To our audience, we also want to thank you for your participation. I think we had a wonderful conversation. Before I sign off, one last thing I'd like to say from Brother Shane McGregor. He asked, is the jelly finger necessary, or is a PSA sufficient for prostate cancer screening? And you need the jelly finger, Shane. You got to get the jelly finger. So with that being said, brothers,
want to know.
yeah, exactly. So with that being said, thank you, everyone. I hope you had a very good time enjoying this enlightening conversation, and we'll sign off with that. Good evening.
Thank you.
Thank you, Brother Rodgers, and thank you, Brother Anglade. That was a great session, and I'm sure our viewers were able to learn an array of new things. And huge thank you to everyone for joining us on this Tuesday night. Next month, on Tuesday, September 7th at 7 p.m. Eastern, we will be featuring Brother Carlos Moreno, the CEO of Big Picture Learning, and it'll be moderated by Brother Eldridge Gilbert of Coney Island Schools. The topic will be education leadership in our communities, and we hope to see you there, and please spread the word. Off to you, Brother Ferguson.
Thank you so much, brother. As mentioned, we are so grateful for your participation in our Alpha Gamma Conversation series. Thank you again for your contributions as well to the Joseph G. LeCount Scholarship Foundation. All of this money will go to a deserving student in the Providence, Rhode Island, matriculating to a four-year college. So we're very excited for your donations. Remember, we do plan to have an in-person celebration the weekend of September 23rd, 2022 in Providence. Until then, eat your vegetables, get your exercise, get the vaccine, and we'll see you next month.
The Alpha train is a slowly coming. I gotta keep on pushing. The Alpha train is a slowly coming. I gotta keep on pushing.